It's time for another 3-question warm-up. Let's get going. First question here, which embryologic structure of the heart gives rise to each of the following adult structure? So first we have the ascending aorta in the pulmonary trunk. That's going to come from the truncus arteriosus. Next we have the coronary sinus. That's going to be derived from the left horn of the sinus venosus. And then next we have the superior vena cava, and that's going to be the right common cardinal vein and the right anterior cardinal vein. Next question. What is the karyotype in Klinefelter syndrome? What is the karyotype in Turner syndrome? So remember, in Klinefelter, that's going to occur in males who are genetically 47XXY. Now, as a reminder, these patients are very tall with long extremities. They're going to have some testicular atrophy and gynecomastia. Those are going to both be common presentations in Klinefelter. Then we have Turner syndrome. That's going to occur in females who are 45XO. You might recall these patients have short stature, a neck webbing, and a shield chest. Next question. Which amino acids are found in large concentrations in collagen? So remember, in collagen, you're going to find lots of glycine, lots of proline, and then hydroxyproline. All right, that's it for the warm-up. Let's get to that lecture now.
So far we've covered staph species and strep species, and now we're going to cram all the other gram-positive bacteria into a single video, or at least the bacteria you're likely to see on step 1. And we're going to start with 2 types of gram-positive bacteria that form spores. Spores are a dormant form of bacteria that are formed when conditions get harsh or when nutrients get limited at the end of the stationary phase of the growth curve to avoid dying off completely. Spores are extremely hardy, and they tend to be resistant to lack of nutrients, desiccation, heat, cold, disinfectant chemicals, that sort of thing. So when times get tough, certain bacteria, specifically Bacillus species and Clostridium species, will form spores that can lay dormant in inhospitable conditions until more favorable environmental conditions arise, and then they can become actively replicating bacteria again. Now, USMLE occasionally asks questions about sterilizing surgical equipment, so it may be worth knowing that you can kill bacterial spores by autoclaving at 250 degrees Fahrenheit, which is 121 degrees Celsius, for about 15 minutes. Now, these are spores of Bacillus anthracis, the bacteria that causes anthrax. And here you see Clostridium tetani, which is the bacteria that causes tetanus. So the gram-positive rods are the normal bacteria, but on the ends of some of them, you can see these little spores forming, which make the bacteria look a little bit like a chicken leg. We're going to cover Clostridium and Bacillus in a moment, but I also want to briefly mention another spore-forming bacteria, which is Coxiella burnettii. Coxiella is a gram-negative rod that causes Q fever. We're going to cover it in the video on zoonotic diseases. But back in the 50s and 60s, when the U.S. government had a biological weapons program, it included stockpiles of Coxiella and Bacillus anthracis and botulinum toxin, all from these spore-forming bacteria. Let's dig into the bacteria in the genus Clostridium. Now, these are all very testable, and at least one of these is something you're probably going to see a lot of in the hospital. Clostridia are spore-forming gram-positive rods that are obligate anaerobes. There are 4 main Clostridium species that we're going to discuss. Clostridium difficile, or C. diff, is one that you'll probably get to know all too well during your clinical years. C. diff makes 2 major toxins, toxin A, also known as enterotoxin, and toxin B, or cytotoxin. So toxin A binds to the brush border of the gut and leads to intestinal fluid secretion and inflammation. And toxin B, which is even more potent, causes disruption and dysfunction of the actin cytoskeleton in the intestinal mucosal cells. Now, this results in pseudomembranous colitis, where inflammatory debris forms a film or pseudomembrane that covers the mucosal surface of the colon. C. diff colitis usually manifests as diffuse, watery diarrhea. It may lead to dilation of the colon, called toxic megacolon, and even perforation of the colon. And the primary risk factor for developing C. diff colitis is antibiotic use. So you inadvertently kill off the normal colonic flora with your antibiotics, and that allows C. diff to overgrow, and that leads to colitis. So anytime you have a patient with new diarrhea while taking antibiotics, you need to think about the possibility of C. diff. And C. diff colitis can even occur after the patient has completed their antibiotic course. So you have to ask about recent antibiotic use in any patient with diarrhea. Clindamycin is a very common culprit, but really any antibiotic can do it. So if you suspect C. diff colitis, how do you diagnose it? Well, you can check for C. diff toxin in the stool, either by PCR or by ELISA. And then how do we treat C. diff colitis? Well, first-line treatments include either metronidazole in patients with mild disease or oral vancomycin for more severe disease. Metronidazole can be given either orally or intravenously because the metronidazole is actually excreted into the bowel, and so it can treat the infection there. And we usually give vancomycin IV, but vancomycin is not excreted into the bowel, so IV vancomycin is useless for C. diff colitis. And oral vancomycin is not absorbed by the GI tract, so it's all going to stay in the gut and kill the bacteria. Another newer treatment option is a macrolide antibiotic called fidaxomicin, which is mainly used for recurrent C. diff colitis that's not responding to anything else. And then another option is the fecal transplant or fecal bacteriotherapy, which is where you take feces from a healthy donor and you infuse it into the C. diff patient's colon as an enema. So the idea is that you're transplanting all those normal, healthy bacteria into the patient who has C. diff, and it works well in about 90% of patients. And on that slightly unsavory note, let's move on to another Clostridium species, which is Clostridium tetani. Clostridium tetani is the bacteria responsible for tetanus, which, thanks to immunization, we don't really see much anymore. Clostridium tetani forms spores that can survive in the soil for long periods of time. So you step on a nail or you get some type of puncture wound, and then the spores from the soil enter the wound and transform into this gram-positive rod that can produce tetanospasmin or tetanus toxin. So we discussed that one in the video on bacterial toxins. Tetanospasmin blocks the release of inhibitory neurotransmitters like GABA and glycine, resulting in increased firing of motor neurons. And this leads to muscle spasms and trismus, or lockjaw, that tetanus is well known for. Now, as I said, we prevent this illness with tetanus immunizations. In general, people need tetanus boosters every 10 years. So if a patient seeks medical care for some wound, and he hasn't had a booster in the last 5 years or more, it's recommended to go ahead and give a booster at that point. Our third species is Clostridium botulinum. So this species produces a heat labile toxin that inhibits acetylcholine at the neuromuscular junction, causing a flaccid paralysis. And remember, we don't recommend giving honey to babies because honey may contain Clostridium botulinum spores. So these spores can transform into reproducing bacteria, which can eventually populate the intestine and produce botulinum toxin that causes symmetric weakness in babies. And then Clostridium perfringens is the last one. Remember, this is one that can produce alpha toxin, a phospholipase that causes gas gangrene and myonecrosis, as well as an enterotoxin that's responsible for a large number of food poisoning cases. Now let's talk about the other spore-forming gram-positive rod, Bacillus anthracis. So this is the bacteria that causes anthrax. Bacillus anthracis produces anthrax toxin, which has 3 components: edema factor, lethal factor, and protective antigen. Now, anthrax can cause different syndromes depending on where the spores land in the body. There's alimentary tract anthrax, cutaneous anthrax, and inhalational anthrax. Cutaneous anthrax is the most common form. This occurs when spores get under the skin, usually through a small skin wound. So a small papule appears first, and then that transforms into a large, painless ulcer with central necrosis, seen as a large, depressed, black eschar. There's often a significant area of edema and erythema surrounding this ulcer due to toxin production. So this is a woman with Bacillus anthracis infection of the soft tissue around the eye, showing all that soft tissue edema that occurs with this disease. And this is an example of that large necrotic ulcer with a black eschar. And this is a lady who worked in a goat hair processing mill, which I didn't really know was a thing. But cutaneous anthrax occurs as a result of handling animals or animal products that contain the Bacillus anthracis spores. And in this case, the spores were in the goat hair. The other form of anthrax you're likely to be tested on is inhalational anthrax or pulmonary anthrax. So if anthrax spores are aerosolized and they're small enough to reach all the way down into the alveoli, they can be phagocytosed and taken to the mediastinal lymph nodes where the toxins cause trouble. So what you see on chest x-ray is mediastinal widening from that lymphadenopathy. The bacteria can then enter the circulation and cause widespread infection and sepsis and death. This form of the disease is sometimes called wool sorter's disease, because the anthrax spores contained in contaminated wool would be aerosolized and inhaled by wool workers, people working with wool. Now, these days, we're a little more concerned about transmission by weaponization of anthrax spores, as a bioterrorism weapon. I mentioned that Clostridium species are obligate anaerobes, but obviously, if Bacillus anthracis can live in the lungs, it must be able to tolerate an oxygenated environment. But it's not an obligate aerobe. An obligate aerobe requires oxygen in an aerobic environment to grow and produce energy. Bacillus anthracis is a facultative anaerobe, meaning it can also grow in an anaerobic environment. Clostridium species, on the other hand, are obligate anaerobes. This means that Clostridia cannot grow or produce energy when oxygen is present. Now, other bacteria that are obligate anaerobes include actinomyces, which we're going to talk about next because it's another gram-positive, and also the gram-negative rod Bacteroides. So those are all obligate anaerobes. And as a reminder, what antibiotics do we typically use for anaerobes? Classic antibiotics should come to mind are metronidazole and clindamycin. At the top right of the gram-positive algorithm, there's a section for branching filaments. So these are gram-positive organisms that have a filamentous growth, resembling fungal hyphae. These include actinomyces and nocardia. Here's a photomicrograph from a brain abscess that shows actinomyces israelii using fluorescent antibody staining. So you can see the shape of the filamentous growth. Actinomyces are anaerobic organisms that can colonize the oropharynx and the GI tract. Now usually they don't cause any problems, but occasionally actinomyces will cause cervicofacial infections, infections around the face and neck. Usually it's in the area of the jaw, the mandible. So this man has developed an actinomyces infection near the TMJ, the temporomandibular joint. So usually what you see is inflammatory changes on the skin, then development of sinus tracts that drain pus and what we call sulfur granules. Now these sulfur granules don't really contain sulfur. They contain colonies of yellow pigmented bacteria surrounded by white blood cells, and they look a bit like granules of sulfur. So the mnemonic was that Israel has yellow sand, so Actinomyces israelii has yellow pigment that can be seen in these sulfur granules. Now, do you remember the other bacteria known for producing a yellow pigment? Staph aureus. Remember, aureus means gold. Now let's contrast Actinomyces with Nocardia, the other filamentous bacteria. Nocardia is a gram-positive filamentous rod that is partially acid-fast, meaning that it stains with the acid-fast staining used for mycobacteria. That's usually going to be your clue on your test questions. Nocardia looks a lot like Actinomyces, but it's aerobic, whereas Actinomyces was anaerobic. Nocardia is fairly ubiquitous. It's found everywhere, in soil, dust, decaying vegetation. It's also part of the normal oral flora. It usually causes infections in immunocompromised patients, either by inhaling it or having it inoculated into the skin. This is a pretty severe case of cutaneous nocardia, but it's a good example of the skin lesions that you can see. Let's get back to some of the more common gram-positive rods, like Listeria monocytogenes. Listeria is a facultative intracellular organism, so it doesn't have to live inside your cells, but it can. Sneaky, sneaky. It enters the body through the GI tract through unpasteurized milk and cheese and also contaminated deli meats. So it enters the body through the GI tract, it penetrates the intestinal mucosa, and it's eventually taken up by the monocytes. So the name Listeria monocytogenes is a good clue to help you remember that it's an intracellular parasite that likes to live inside of monocytes. Now, if a pregnant woman is infected, the bacteria can cross the placenta, resulting in fetal loss or neonatal sepsis. So you remember the three major organisms associated with neonatal sepsis? Group B strep, E. coli, and Listeria. So this is why pregnant women are told not to eat soft cheeses or drink unpasteurized milk or even deli meat during pregnancy. Now, the main groups at risk for Listeria infection are infants, especially newborns, the elderly, immunocompromised individuals, and pregnant women. The last bacteria we're going to discuss in this video is Corynebacterium diphtheriae, the scourge of spelling bee contestants throughout the land. Again, this is a gram-positive rod, but it has these protuberances on either end of the rod, kind of like a club. That's where the name comes from. Karuna is a Greek word for club. Not that kind of club. The kind of club you would use to bash somebody's head in if you were a caveman or something. And as you might also guess from the name, this is the organism that causes diphtheria. But many of the clinical manifestations of the infection are actually due to production of exotoxin. Diphtheria toxin is an ADP ribosylator of elongation factor 2. Now, you reviewed this in the video on bacterial toxins. Do you remember another bacteria that produced a toxin that inactivates EF2? Pseudomonas aeruginosa. It produces exotoxin A, which has a very similar mechanism of action. Diphtheria toxin can damage nerve cells and also heart cells, so diphtheria can cause cardiac arrhythmias and myocarditis. But the most striking manifestation is pseudomembranous pharyngitis. You see whitish patches in the posterior oropharynx that coalesce into a grayish membrane that adheres very tightly to the surface. And if you try to scrape this off, it bleeds profusely. Now, this membrane can proliferate within the respiratory tract and can be associated with mucous membrane inflammation, which causes a so-called bull neck of diphtheria. Lots of soft tissue swelling, which is pretty bad for respiratory function. Making the diagnosis of diphtheria requires both a positive culture and proof of toxin production, either by PCR or a test called the ELIC test, which is where you put a special filter paper on the culture medium and then the toxin precipitates out on that paper. Now, we don't see diphtheria very often in the U.S. anymore because we immunize children against it. This is the D in the DTaP vaccine or the DPT vaccine. But diphtheria is not uncommon in other parts of the world. So, how do we treat it? Well, infected patients need antibiotics such as erythromycin or penicillin to kill the bacteria, and also antitoxin to inactivate the diphtheria toxin. You also need to vaccinate these patients after they start to get better because natural infection does not induce protective immunity. Now it's time for the end of session quiz. So pause the video and answer those questions, then we'll go over the answers together. First question, which gram-positive organism matches each of the following statements? An infant with poor muscle tone should make you think about Clostridium botulinum and botulinum toxin. Diarrhea after using antibiotics, think about Clostridium difficile or C. diff. A gray-white membrane in the posterior oropharynx of an unvaccinated child is Corynebacterium diphtheriae, causing diphtheria. Serious neonatal infection, think about group B strep or listeria. And then the third one was E. coli, which is actually a gram-negative. Nodular skin disease containing gram-positive filamentous rods that are partially acid-fast is nocardia. Gram-positive rods spread in unpasteurized milk and contaminated deli meat is Listeria monocytogenes. And then respiratory distress in a postal worker is a clue for Bacillus anthracis. So back in 2001, right after the September 11th attacks, there were some bioterrorism attacks in which anthrax spores were mailed to senators and also news media. And a handful of people got sick and died. So if they give you a clue related to the Postal Service plus pulmonary disease, they might be trying to point you toward pulmonary anthrax. Next, which patients are most susceptible to Listeria monocytogenes? Remember, infants, the elderly, immunocompromised, and pregnant women are all especially susceptible. And remember, Listeria can cross the placenta and cause fetal demise. Next, which bacteria are spore formers? So the spore-forming bacteria we went over were Bacillus and Clostridium species. So that includes Bacillus cereus, Bacillus anthracis, Clostridium perfringens, Clostridium tetani, Clostridium difficile, Clostridium botulinum, and then you should also remember Coxiella burnetii. And the last question, which medications are commonly used to treat C. diff colitis? So metronidazole or oral vancomycin are first line, and then fidaxomicin is another option for recurrent C. diff colitis. We also have one rapid-fire fact. Branching filamentous gram-positive rods with so-called sulfur granules, that's Actinomyces israelii. That's it for now. I'll see you next time.